Good, thank you very much, and I appreciate the invitation to be here. Congratulations on an excellent event. So what I'd like to do is get started, and I want to just bring some management points up, and actually what my plan to do is bring up some of the most common questions that are presented to me by parents or athletes or coaches. So hopefully this is useful and practical. What I'll do is go through a very brief part of the pathophysiology. I think there's a few important take-home points that I want to really send with you and drive home. Then we'll talk about the initial and subacute management principles and return to play criteria. Hopefully we have some time to discuss prolonged recovery, the outliers, the folks who don't recover on a normal recovery pace, but I'll be available for clinicians if they want to corner me in between sessions or afterwards. I'd be happy to talk about specific management principles if we don't get in depth for that discussion. But we'll talk briefly, very briefly, about the pathophysiology. The normal anatomy, the normal function of the neurons is there's a gradient, an ion gradient with sodium and potassium. An impulse is sent down the axon of the nerve, and neurotransmitters are delivered. That's how the impulse is transmitted. During injury, there is a disruption of that normal gradient. There is a massive efflux, outpouring of potassium from the cells, a massive influx of calcium into the cells, and this disrupts that gradient. So it makes it difficult or sometimes impossible for the impulse to travel down the axon. And I bring this up partly because it brings up two important points. Number one, this sets up an energy crisis, a metabolic issue, a metabolic supply and demand issue, and I'll explain that in just a moment. But I bring it up also because a lot of patients and parents come in and they think concussion more like a bleed. They think of it more like a bruise of the brain, and they're in particular they're interested in why aren't we getting MRIs, why aren't we getting CAT scans so we can measure the bruise, the hematoma, the bleeding. It's really not like that, unfortunately. In a lot of ways, unfortunately. It won't show up on standard imaging like CAT scans and MRIs. Now, we do CAT scans and MRIs if we think there's fracture or intracranial hemorrhage. But the fact is our standard clinical imaging is not sensitive enough to bring up abnormalities in concussion, so they will appear normal. And this can be frustrating for parents and coaches and players because it's not a tangible injury that you can see. It's really on the cellular level. So think about some of these slides perhaps, and it really is a metabolic issue at the cellular level. It's a disruption in the way the cells function, not large disruptions in structural injury. And I said metabolic crisis. It's during this injury that there's a window of vulnerability. There was a question about, the question was, I'm not sure how you phrased it, but returning too early, I think, was one of the questions. We'll talk about returning criteria. But Chris mentioned this, the window of injury, that athlete is particularly vulnerable to exponentially worsening their symptoms with new collisions, even collisions that they would normally shrug off. Simple, collisions, shoulder-to-shoulder collisions, intentional heading of a soccer ball. Those mild collisions will exponentially worsen that person's symptoms, lengthen the recovery, and increase the chance of poor outcome during that window of vulnerability. And there's a period, in the beginning where there's actually an increased demand for glucose. So that ion gradient is generated by ATP. The cell actively pumps in the sodium, pumps in the potassium, pumps out the sodium. So when it's trying to re-establish that gradient, there's an increased demand for glucose in each individual brain cell. And during that time after injury, there's a decreased blood flow, decreased glucose delivery. Among other things, these glutamine changes. But the point is, during a time of increased need for supply, there's decreased interrupted delivery. So that's the metabolic crisis, if you will. And I bring that up just to help answer some of the questions that, again, come up in my office frequently. We have 10 clinicians, and we see anywhere from 300 to 500 patients per month. During the busiest season in the fall, we'll do 6 days a week at the concussion clinic. We'll see a massive amount of patients, but the questions and the issues are pretty consistent. The parents in particular have familiar questions that come up frequently. So we'll talk about management principles. First, it's remove from new collisions. Remove from contact sports and other recreational activities that they may get new collisions, because remember, they're vulnerable during that period of time. We institute physical rest and cognitive rest. And I'll come back to this a bit. We do very aggressive physical and cognitive rest in the beginning, although if we get some time to talk about prolonged recovery beyond the 4 to 6 week mark, there is a period where you can overdose rest and people can get physically deconditioned, socially isolated, really increase their stress when they're missing school. So we'll talk about dosing of rest if we have a few minutes, but the principle is remove from new collisions, physical and cognitive rest, let those brain cells recover. We have to, of course, manage expectations, and especially if you're in a group practice, I think you need very rigid, or I shouldn't say rigid, but consistent principles, so that if a patient sees me this week and I'm away speaking in Ireland, and one of my patients has to come in and see one of my partners, they're getting the same message consistently. And you want to, when we're in an office environment and I'm talking to the athlete about return to play, when I see them on the first visit and the second visit, I want them to hear the same mantra. You'll hear me talk about 4 criteria for return to play. Symptoms recovered, academics are tolerated, exercise stages are tolerated, and then some sort of neuropsych testing. We usually use computerized testing, and I'll come back to that principle of the 4 indications for return to play. So on the field, coaches and players should be aware of monitoring for concussion symptoms, and at least being aware of when an athlete should be evaluated by a trainer or a medical doctor. They should also, whoever's responsible for medical care needs to know cervical spine management if there's head and neck injuries. Off the field, we'll talk about what the next few steps are, but on the field, these are some of the symptoms of concussion, and one of them is loss of consciousness, although that is actually present in less than 10% of cases. So we've seen a lot of videos of dramatic injuries, loss of consciousness, big collisions, and people sort of stumbling off the field. Those are clearly concussions, and I'll tell you, the most difficult management is the marginal cases, the mild concussion, if you will, especially those that are away from the play, those that are not the ball carrier. So you can imagine some of these players, big collision, loss of consciousness, maybe even post-concussion seizure right on the field. Most of us are on the same page for that. That athlete will come off, they won't return to that contest, they'll be managed with kid gloves, if you will. It's such a scary event that people will be motivated to say, we're not going to return this player until they're recovered. But imagine another player far away from the ball, gets a big collision, has some symptoms, doesn't pass out, and is concussed, but no one quite is clear about it. That person's in that window of vulnerability. That person, if you look back, that'll be the type of player that will have prolonged recovery. If you look at all the players with prolonged recovery and difficult outcomes and look back, most of them are multiple collisions in the same contest without identification before they're withdrawn from that play. So loss of consciousness is not required for the diagnosis of concussion. And in fact, it's the vast minority of cases where there's loss of consciousness. Sometimes it's as simple as a change in performance, where the athlete's just changing, just subtly changing what they're blowing assignments or just not acting like themselves. And there are delayed symptoms. So again, I see mostly athletes in the school age, so between 12 and 22. So they have a big school requirement. Sometimes it'll be delayed injury, and they'll come in and they'll play on Saturday, and they'll feel okay Saturday and Sunday. They come in Monday for school, and they struggle, and they have headaches and sensitivity to light. Their school performance drops, and that'll be their first sort of presentation that they know something's wrong, and we'll investigate there. On-field assessment. So I use the standardized assessment of concussion on the sideline, and I'll show you a little card for those of you who are not familiar with it. This is one of the keys. How do you identify concussion? How do you make the diagnosis? We're very sensitive for any symptoms. Frankly, we've made a commitment, particularly at the high school level, to say if there are any signs or symptoms of concussion, that athlete will not return to play that day. And I'll have a fairly low threshold for withdrawing a player from football, which is American football, which is what I cover most commonly. I'll also, if they're injured and we're assessing them, we'll use this SAC, and it measures immediate and delayed memory. There's number sequences. There's an exertion part. So this is the card that I use, and it's laminated and I put in my pocket. So they'll get a point it's a point system. If you're not familiar with this, I think you should be. It's a very useful tool, and it's free to use as opposed to computerized testing, which requires some investment. You get a score of 30 points. This is the kind of thing that would be useful to have preseason baseline testing, because it's actually a fairly challenging test, and not everyone is, in fact, most people are not going to get 30 out of 30 points. You get a point for orientation, what day of the week, what year, what approximate time of day is it, and then we'll give them 5 words and say, pencil, truck, ball, flag, bubble. And they'll get a point for repeating back that list to me, pencil, truck, ball, flag, bubble. We'll do that 3 times, they get points. And we'll again come back to that as delayed recall later on. We'll do some other things like physical exam, months of the year in reverse order. We'll have, if they're still symptom free, by the way, if they're having symptoms when I'm doing this assessment, I'll complete this test, but they're not going to return to the contest. If they're symptom free, we'll have them go do exertion, push-ups, running, exercise, see if there's symptoms, if they have symptoms. And then we'll do delayed recall. What were those objects? Pencil, truck, ball, flag, bubble. So this is just one example of a tool we use. It is not foolproof, but it's one of the few cognitive assessments, right, functional assessments of what we use on the sideline. We can't practically use computerized testing. It takes about 20 or 25 minutes to do that, so it's not practical for sideline use. But a functional test for a knee, we'll push and pull and see if there's subjective symptoms. Is it painful? Is it tender? We'll push on the function of the ligaments. We'll push valgus stress, Lockman testing to test the function of an ACL. Brain function is difficult to measure, so we have to do at least some addition of cognitive assessment, and this is a crude tool. It's probably most useful when it's very low. If it's normal, it's still clinical judgment whether that person is injured or not, and I have a very low threshold for keeping that player out. And again, baseline testing, preseason testing is useful because it's actually a fairly challenging test. We only do ED, emergency department evaluations, if we think there's fracture or bleed. We really try to limit CAT scans. That's the best test in the immediate management. If there's delayed recovery, 4 and 6 weeks, if they're outside the normal range, we may do MRI imaging. But we try to limit, because of radiation exposure, limit the amount of CAT scan exposure, partly because it's not diagnostic for concussion. Really, we're doing that to rule out other injuries, intracranial hemorrhage, fracture, things like that. So then we've made the diagnosis on the sideline. What's our next couple steps? Well, we're going to send the athlete home with some information, make sure there's communication with parents. We want to make it clear that they're going to be out of games and practices until we meet our return to play criteria, which we'll go over in a moment. Avoid other activities that are high risk, like skateboarding, skiing, things like that. And then optimize what we can optimize. We talk about headache management, optimize what we can optimize, sleep, nutrition, hydration. So the fellows that in our training system, they sort of know it's like a mantra that go through these words or these phrases we go over several times, those 4 return to play criteria. We talk before they leave, optimize sleep, nutrition, and hydration. And sleep quality is hugely important, especially as the athlete goes through their recovery. If they're out of school for a week, which is common, typically we'll take them out of school for 3 or 4 days, maybe 5 days, and then try to return them to school with academic accommodations, which is difficult. That's probably the most difficult part of the concussion management, is the balance between rest and school requirements and the accommodations that we're asking the school to make, which we'll review again in just a moment. But we don't want them home doing nothing, sleeping during the day, then not sleeping at night. You can bet they wake up sluggish, irritable, headaches, many of the symptoms of concussion if we get into a physical deconditioned state. So we try to regulate daytime and nighttime sleep schedules. I asked them fairly early on to do stretching and walking each day, at least to keep them somewhat engaged, not doing running, not doing push-ups, certainly not doing contact sports, but after a period of a week, do at least something to get them structure to the day, where they're not just sitting home, staring at the walls, getting irritable, getting stressed out about school, again, napping all day and then not sleeping at night. So it's a balance for sure. Return to play criteria. I mentioned this once, and I'll mention it to the patient 4 or 5 times throughout the appointment. And again, the reason is we want to be consistent, and we want to be consistent across our clinicians that are seeing other patients too. So when we talk about when do you return, it used to be we would use these criteria that would say, well, if there was no loss of consciousness, return in 1 week. If there's loss of consciousness more than a minute, return in 2 weeks. If it's a second concussion in the season, return in 4 weeks. Well, as it turns out, loss of consciousness does not predict the severity of the injury, and it's not very useful actually for predicting when that player should return. And as we talked about, some of the worst outcomes are from those players that did not have loss of consciousness and had multiple collisions. So instead, we use an individualized approach and say, well, we're going to expect resolution of symptoms back to pre-injury baseline. So if someone always had trouble sleeping, or if they have always had trouble concentrating, maybe they have ADD or ADHD, we want them to return to their pre-injury personal baseline. Okay, and I'll show you the symptom score sheet that we use with that. But we expect resolution of symptoms back to pre-injury baseline, academic tolerance, they're back to full days of school, full schoolwork. Exercise tolerance, we go through stages of non-contact exercise, and we expect no return of symptoms. And then we'll typically do some form of neurocognitive test. I usually use, we use impact test, which is a computerized test. If that's not available, you can use something else like that SAC score that we talked about. These are the symptoms. I know it's kind of small, I apologize. This comes from the Zurich concussion statement that I would consider required reading for some of the principles we're talking about. I've just grouped them into domains. The somatic domain are the physical symptoms, headache, dizziness, nausea. The vestibular or balance domain. There's the emotional domain of irritability, sadness, or nervous and anxious. And actually, that's some of the most striking symptoms. We were just talking about this with a colleague, where some of these athletes will get injured and they'll have quick, just tears for no reason, inappropriate laughter. That really gets people's attention. But we just separate these symptoms into different domains. The cognitive domain and the somatic domain, the physical symptoms, headache being the most common symptom that folks report, particularly with prolonged recovery. And then sleep is the last domain there. Again, we go back to return to play criteria. When symptoms are recovered, as symptoms are recovering, so we do aggressive rest for the first week. I will consider returning athletes back to school with symptoms if they're mild and if they're not exacerbated severely by schoolwork. And the reason this is important, this probably gets more into prolonged recovery, but I think it bears repeating. At 2 weeks and at 3 weeks, if that athlete's still out of school with symptoms, we have a decision to make. If they're mild symptoms, I'll actually return them to school with accommodations. And I'll accept a certain amount of symptoms. If it's worsening exponentially, I'll have them go to the nurse's station, rest, try to come back to schoolwork. And the reason I do that is some of the clinicians in the area have gotten the message that concussion is important and rest is important. But what will happen is they'll take them out of school, and they'll be out of school because they still have some symptoms, and they were told, don't go back to school until you're symptom-free. But at 3 weeks and 4 weeks, and even I've seen patients who are out of school for 5 weeks. Now, both my parents were teachers, so I know this is just not what we did when we were sick at home. We'd be maybe half day and you get back in school. But I think returning to school gives them a couple things. Return to their structure. Most of the students are actually, that I see, are actually worried about their schoolwork. They're invested in it. Especially good students, they get stressed out when that schoolwork is building up. And actually the accommodations, the schoolwork accommodations, the concern automatically may be, well, kids are going to take advantage of longer time for tests and projects, longer time for making up homework. But the fact is, I don't see it abused very much. I think that the athletes, particularly the ones who are involved in athletics, are motivated to catch up on the schoolwork and to get back to their athletics. So I don't feel like the accommodations we put in really are abused. But we expect academic tolerance if we're going to move on to the next step. And academic accommodations will send them along with a school note to say, once they can tolerate 30 minutes or 40 minutes of reading, we'll get them back in schoolwork with a note to say we'd like to have them defer high-stakes tests till later, longer time for projects and tests. And if you want to read something which I think is extremely helpful, sort of lays out some of these criteria, the Zurich guidelines, I think, are a good starting point, but the pediatrics just put out a paper on returning to learning, and it has some very good practical information about the return to the school classroom, which is really tricky. I'll tell you, that's some of the hardest management we have, particularly in prolonged recovery, the school performance. But it's, of course, their primary job. We talk to the athletes and we talk about their occupation. It is student first and then athlete second. But that's really two jobs and a lot of stress for those individuals. When they're tolerating full days of school, when their symptoms have resolved, then we'll go beyond the stretching and walking. Then we'll start with stages of exercise: light, then medium, then high intensity exercise, non-contact. If they do well with that, we'll consider testing and perhaps return to practice and games. We can give them printout sheets. Some people really want to get into their training and they say, well, we'll even print out percent of maximal heart rate. They'll follow along. But general rule of thumb I think is useful. Again, I start them out with stretching and walking fairly early. When we start light, non-contact exercise, I like to start stationary bike because there's no bouncing and moving around like running on a treadmill. And I tell them light exercise where we could keep a conversation if we were on bikes next to each other. Medium intensity is where you have to take a breath if we're on bikes next to each other. And then high intensity will be push-ups, sprints, really high test exercise, simulating practice, but non-contact. So the stages in between each one are individualized. So if it's a 12-year-old athlete with third lifetime concussion and they're now at 6 weeks or 7 weeks before their symptoms have recovered, I'm going to go fairly slowly. We may do a week or longer between each stage of recovery, expecting success at school and no return of symptoms during or after exercise. If it's a college or university age athlete, first lifetime concussion, brief mild symptoms, we may advance them fairly quickly, 1 or 2 days of success in between each stages. So it is individual. And I'll tell you, the dosing of rest, physical and cognitive rest, is still being worked out. And what's the optimal dose? How much is too much? How much is not enough cognitive rest? And the stages between each, the time between each stages is also still being fine-tuned to say what is the best course of action. But in general, for younger athletes, we take a much more conservative approach. We look at their history. What was their number of concussions? How long did each concussion take? What was the mechanism of injury? This is important too. If it's high energy injury with a lot of symptoms, well, that makes sense. If it's low energy injury and the kid comes in with a lot of symptoms, struggling in school, and it was only a simple sort of shoulder collision, that really gets my attention. And we'll really take a slow approach and really discuss their personal threshold for injury. So the mechanism really gets into your management. Lastly, for return to play, we think about neurocognitive testing. We use this computerized test called impact test. It takes about 20 or 25 minutes, measures reaction time, motor speed, verbal memory, visual memory. And it's useful particularly if there's a pre-injury healthy baseline. There was a question about baseline testing earlier. Yes, I do encourage baseline testing, and it's valuable, extremely valuable tool. And the question was, I think, can some of the athletes sort of submarine the baseline test, intentionally do poorly on it, so that if their post-injury test comes up, they can easily match their pre-injury scores. And the fact is, these computerized tests are actually really sophisticated. There are internal quality control measures that you can sort of do surveillance for. You can find out most of those folks who are doing it, but it takes, interpretation of this test takes extra training. So these computerized tests, CogSport is used frequently, I think, in Europe, and impact test is frequently used by us in the US. You really have to be trained to interpret it. So it's like an x-ray. Useful tool, fairly easy to administer, but if you're not trained on interpreting it, it can be more dangerous than it's worth, I suppose. Prolonged recovery, and how am I doing for time here? Prolonged recovery, yeah, okay, so we'll wrap up a few things, but prolonged recovery, if there's particularly prolonged headache, think about other causes of headache, right? Not just the brain injury, not just the brain cell, especially right at the occiput, right at the nuchal ridge in between the mastoid process and the mid portion of the skull. It's where the exit of the occipital nerve is, and palpate there. It's not infrequent at all. In fact, it's fairly frequent for folks to come in and they have return of good cognition, but they have continued headaches, and they may have tenderness, reproducible tenderness, right at that nuchal ridge, and they get that classic tension myofascial frontal headache, and you can reproduce it with palpation at the nuchal ridge or myofascial trigger points of the trapezius. So the point is, don't forget cervicogenic headaches from the whiplash action, the myofascial part of this. sometimes the headache continues, but it's not really purely concussion anymore. It's headache management. I still don't return them to contact play until we resolve that, but other things like trigger point injections, massage, acupuncture, physical therapy can be very effective for those. There are medications that are off-label use, and if clinicians are interested in talking about that, I'll be happy to talk about specifics of the medication on the side, but it should be, I typically don't consider them until about 4 to 6 weeks of failure of conservative measures, and only if clinicians are aware of their side effects and potential downsides, and only if the burden of symptoms outweighs the risk. All right, and I'm going to move through this. I mentioned most of this. Be careful of the overdose of rest and deconditioning. Other prevention strategies include neck and postural training, core strengthening to prevent awkward falls and head whiplash. And then the last thing which comes up, I'll be brief on this. How many is too many? This is neurosurgery is proposed. 3 as a line in the sand. Now I'm a little careful to not draw a line in the sand for a reason that's I think important. If we have an athlete with 2 concussions and I say, okay, 1 more injury and that's it, pretty quickly they will figure out, they'll be on the side, they maybe get hit and they don't feel quite right, but they say to themselves, well, is this enough for me to retire? I'm not sure. I think maybe I'm just going to keep this one to myself. So I don't want to close the communication. But if there is injuries, if there's a pattern of decreasing force, right, multiple collisions with decreasing force, it's getting easier, or longer recovery, or incomplete resolution, that's perhaps time for taking a full calendar year off, physical reconditioning, change position, or retirement from that sport. So I'll wrap up here. I congratulate you all for being here and taking the time to listen to me drone on. I'm going to be here for questions, and hopefully that's some of the basic principles. I put up this slide to remind you of some of the useful reading. Bill Mee and my partner put out a good book for coaches and parents, and the Returning to Learning paper I think is excellent, so it's good reading. And thanks so much for your patience. I'll be happy to take any questions if there are right now, or I'll be available all day if people want to pull me aside, whatever you want. And I'll look to Karen if we're going to, of course we want to keep, I don't want to set things behind, but I'll be available all day if anyone has questions. Yeah? Good? Okay, thanks folks. Yeah.
Do you have a question from over there? Yeah, one from the back row. I think we have a mic. Hang on one sec. Sorry.
Yeah, I think the question was, are there smartphone applications? Yeah, there are a few, and there's some that are trying to incorporate balance testing, and so I'm not sure that any I've seen yet are reliable enough or valid enough where I'd be confident in a normal result. A lot of it's subjective symptom reporting, and you really need the athletes to buy into the fact that we're in this together. We're going to report, I need you to report symptoms, and we're going to assess this carefully. By the way, one of the things about drawing a line in the sand is I really need my athletes to know I'm going to do a careful assessment, and not every hard hit is going to be out for a month, because if that happens, they'll quickly, if they have low-grade symptoms, and I just say, well, okay, see me in a month, and that's it. Quickly, they won't report those mild symptoms. And again, the mild injuries are often the most difficult to treat, and they're the ones that are very vulnerable. So I want, when I'm covering my American football games, I want about 10% or so. I want a couple kids to come over who had a hard hit. The coach says, oh, hey, go check out with Dr. O'Brien. I want to do my assessment. I should have at least some athletes. I say, well, you know what? You look pretty good. Things are going well. You don't have symptoms. Yes, that was a hard hit, but we're not reporting symptoms, and I'm confident in their reporting. Their SAC score is good, their balance is good, and I should probably return a certain portion of them. If I'm not returning a certain portion, I'm probably not seeing enough. They're not being sent over to me frequently enough, or my threshold is off, and I risk closing communication with the athletes. But right now, I guess the short answer is I'm not confident yet in some of those apps. Most of them are incorporating balance, or there's some version of cognitive assessment like the SAC. Yeah, question.
Yeah, I just have a very, Nicola Ryle from the National Rehab Hospital. I just have a very quick question about amantadine and methylphenidate. Is this for patients who have low energy, or what are the,
No.
when do you tend to use it?
Amantadine and methylphenidate we've used when the somatic symptoms are recovered, but they're struggling with cognitive symptoms, specifically concentration. And again, I use it fairly rarely, and I don't use it for speeding recovery. So return to sport is not part of that discussion. So in fact, it probably is going to prolong recovery, because we want them to, if we use methylphenidate for school performance temporarily, we expect them to get off the medication successfully, still be symptom-free, then go through a progression of exercise stages, then maybe return to sport. But we'll use it primarily when somatic symptoms are recovered, but cognitive symptoms continue, and that's actually fairly infrequent. Usually it's the headache that's persistent, if they're going to be persistent symptoms. And I generally don't consider it before 4 to 6 weeks anyway. Yes, question back here with the microphone?
Hi,
Yeah,
I'm just wondering what percentage of students that you see, like 12 to 22-year-olds you were talking about, that never return to sport, because if the concussion is severe enough that they can't go back into contact sport?
Well, that's a great question. And my patient cadre is probably a bit skewed, because we're seeing folks who oftentimes failed good management with their primary care physicians, and they're coming to us as a tertiary referral. So it's probably higher than the typical GP practice, but I would say it's still fairly infrequent. It's probably 2% or so, 2 or 3%, and that falls in line with the folks who, if you just look at bell curves of the folks who are really going to fall outside of the typical 4 to 6 week mark anyway. If you're talking about folks who would never go back to any type of sport like that, it's got to be below 3%. It's actually fairly infrequent, but that'll be for a severe concussion. If there's a pattern, though, well, it's probably right around the 3% mark. We're saying, listen, take a year off or retire from this sport when there's a pattern of multiple concussions. Yeah.
Over here.
Last question here. Yeah, and I have to remember.
Paolo Boldrini, rehabilitation physician from Italy. I understand that concussion is mainly a matter of young male athletes, but have you any data about male-female differences in recovery after concussion?
No, I wouldn't say. Particularly in our experience in the U.S., it's definitely not exclusive to males at all. In fact, there's a huge amount of participation in women's soccer at the high school and college level, and that's one of the higher rates of injury. Now, American football is well number one. Ice hockey, men's ice hockey is second, but women's ice hockey and women's soccer are among the higher on the list, and it's definitely not exclusive to men. There are some discussions about who is more prone to the prolonged recovery, and there's conflicting data about that. Now, our data has suggested that initial symptom burden, the severity of symptoms, is probably one of the strongest predictors. But people have suggested pre-existing migraines or female gender or pre-existing learning disability may make people susceptible to prolonged recovery. I think there's a good consensus agreement that previous injury, and definitely previous recent injury or multiple collisions in that vulnerability window, will increase the likelihood of prolonged recovery and complex concussion. But gender, we see just as many women as men. Yeah, and some of it's number of hours of exposure. So that women are not playing American football, but so the volume, volume by sport, it will be different by participation numbers. But the rates of injury, women's soccer, women's basketball, and women's ice hockey are up there for rates of injury very high.
Dr. O'Brien will be available throughout the day. Big round of applause, Dr. O'Brien. Thanks.